Good morning. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I want to discuss with you normal labor. So, what are the items to be discussed? The definitions of labor, series of onset of labor, forces of labor, uterine phases of parturition, stages of labor 1, 2, 3, and 4. Labor is a process during which the fetus membranes, umbilical cord, and placenta are expelled from the uterus. Normal labor, spontaneous expulsion of single, viable, mature fetus through the natural birth canal, presented by vertex, and this procedure without aid and without complication to the mother or to the fetus, and within reasonable time, I mean within 24 hours. Preterm labor, the duration of pregnancy is between 28 weeks and 37 weeks, while post-term labor, when duration of pregnancy is 42 weeks or more. Prolonged labor, if labor lasting more than 24 hours. Precipitate labor, if labor lasting less than 3 hours. What about the theories of onset of labor? Different theories try to explain the onset of labor, like prostaglandin theory, because prostaglandin present in the amniotic fluid and can be released at the end of the pregnancy and cause ripening of the cervix and uterine contraction. Fetal cortisol theory explain the presence of cortisol, which is important to cause lung maturity and may be associated with increased estrogen and increased sensitivity of the uterus to oxytocin. Progesterone withdrawal theory, as regard the progesterone, when it decreases in amount and it has relaxation effect on the uterus. On the other side, there is excess estrogen and increased contractility of the uterus and receptors for oxytocin. Placental ischemia theory, with the release of decrease of the release of oxytocinase, which distract the oxytocin, so cause uterine contraction. Uterine distension theory, by the baby at full term, this stretch of the muscle wall of the uterus reflected by uterine contraction, and stretch also of the lower uterine segment. Estrogen oxytocin theory, there is a relation between estrogen and the oxytocin receptors at the end of the pregnancy. Neurological factors like alpha and beta adrenergic receptors. Alpha is associated with uterine contraction, so and beta adrenergic receptors for uterine relaxation. So alpha receptor dominate at the end of the pregnancy and cause start of labor. What about the forces of labor? We have uterine contractions and retraction and auxiliary forces of labor. What about for the uterine contraction and retraction? As you see in the picture, The uterine muscle wall characteristically has a property of being retracted after contraction. If you see, this is a muscle fiber. After contraction, it looks like that, while during relaxation, it becomes in that size, and so on and so on. As you see, there is a smaller in size of the muscle fiber because of retraction. This is the only muscle of the body has this character, being contracted and retracted. So the uterine contraction, regular, involuntary, intermittent, and painful. It is of increasing frequency, strength, and duration. Undergoes retraction. When the muscle fiber relaxes, it doesn't regain its original length. Show the phenomena of polarity. The upper segment is more active and the lower segment is passive, so as to dilate the cervix and expel the fetus. What is the significance of uterine contraction and retraction? Dilate the cervix, expel the fetus, separate the placenta, control postpartum hemorrhage. True labor pains due to uterine contraction are felt as colic pain in the abdomen, which is referred to the lower back during contraction. Uterus becomes hard when felt abdominally. Uterine contractions are accompanied by progressive cervical dilatation and the membranes bulge through the cervix when felt during contraction. Intrauterine pressure increases up to 40 mmHg during the first stage and up to 120 mmHg during second stage. The pressure at which the woman feels pain is 25 mmHg. As you see in this picture, there is nucleus start of the uterine contractions start usually at the cornea, the right cornea, then proceed to the upper segment, as you see, then to the whole uterus. And the upper segment is more active than the lower segment. This picture let you see how the lower uterine segment formed. As you see in this picture, this is the external os, this is the internal os, the histological one, and this is the anatomical internal os. The area between anatomical internal os and the histological internal os is called the isthmus. And this isthmus formed the lower uterine segment during pregnancy. It is 1 centimeter at the start, then late in pregnancy increase till reach 10 centimeter. This area is lower uterine segment. This area is lower uterine segment. Okay, what about the effacement of the cervix? This is as regard the effect of uterine contraction. The retraction leads to effacement of the cervix. Shortening or thickening up of the cervix is called effacement. This is 0% effacement. The whole length of the cervix is present here. Shortening or thickening up of the part of the cervix, here 30% effacement to join the lower uterine segment. This is more effacement, reaching 100% effacement. The cervix becomes very thin and join the lower uterine segment with some dilatation here, then complete dilatation with the effacement here in this picture. The upper picture here show the forewater, which is bulging here through the cervix, helping cervical dilatation. This is called forewater. Okay, what is the difference between true and false labor pain? True labor pain is regular, increase gradually in frequency, duration, and strength, while false labor pain is irregular. In true labor pain, there is spasmodic colic pain felt in the suprapubic region radiating to the back, while in false pain it is irregular in site and character. True labor pain is effective because it is associated with effacement and dilatation of the cervix and the bulging of the membranes. On the other side, false labor pain is ineffective. True labor pain increased by enema, while false labor pain decreased by enema. True labor pain not terminated by sedation or mild analgesics, while false labor pain frequently abolished by sedation and mild analgesics. The second force for labor is called auxiliary force of labor. Voluntary bearing down by strong contraction of the diaphragm and the abdominal muscles. When the head reaches the pelvic floor, bearing down occurs involuntarily by reflex mechanism. So auxiliary forces of labor include both voluntary and the involuntary bearing down. What is the significance needed for spontaneous expulsion of the fetus during second stage, and may also expel the placenta in third stage? What about the uterine phases of parturition? We have phase 0, phase 1, 2, and 3. Phase 0 from implantation to late gestation. Phase 1 is called the preparatory stage. Functional changes in the myometrium and the cervix, painless contraction, development of lower uterine segment, and ripening of the cervix. Phase 2, active labor in 3 stages, 1, 2, 3. Phase 3, genital involution and the breastfeeding. Let us go to stages of labor, which is the main core of our lecture. Stage 1, 2, 3, and 4. Stage 1 is the stage of cervical dilatation from the start of true labor pain to full cervical dilatation, which is 10 cm. Primary gravida is different than multigravida. In primary gravida, the first stage constitutes 14 to 16 hours, while in multigravida it is about 8 hours. Second stage, considered the stage of expulsion of the fetus, start from full cervical dilatation to delivery of the fetus. In primary gravida, it is about 1 to 2 hours, while in multipara, it is half to 1 hour. Third stage is the stage of delivery of the placenta and the membranes. Begin with complete delivery of the fetus and end by the expulsion of the placenta and the membranes, usually in 5 to 10 minutes. Fourth stage, it is an observation of the pregnant woman after delivery for 1 to 2 hours for the vital signs and for uterine contraction and for the amount of blood loss after delivery. This is the 4 stages of labor. First stage. What is the etiology? The etiology for first stage is the contraction and the retraction of the uterus, bag of forewater before rupture of membranes, or the presenting part of the fetus after rupture of membrane. As you see in this picture, this is the bag of forewater. The changes in the cervix during pregnancy, what's called ripening, edema, and the softness of fibrous and muscular and the collagen fibers makes the cervix easily dilatable. Number 4, pressure of the presenting part of the cervix. So all these 4 factors responsible for the first stage of labor. As you see this picture, this is the cervix, not effaced and not dilated. This cervix is fully effaced, but only 1 centimeter dilatation. This cervix is effaced and 5 centimeter dilated. This cervix is fully dilated, 10 centimeter dilated. The mechanism. The internal os dilates first in primary gravity, and cervical canal becomes opened from above downward and become incorporated into the lower uterine segment, and cervix becomes thin, but the external os remains undilated, a process which is called effacement or taking up of the cervix. Then it is followed by dilatation of the external os. So as you see in this picture, this is the cervix. This is not effaced. This is cervix partially effaced with some dilatation of the internal os. This is the cervix and it fully effaced, and the internal os opened, but the external os not yet. Then the external os opened here. So in primary gravida, internal os open early and the effacement happened, then external os open at the end. While in multipara, effacement and dilatation of the cervix occur simultaneously. As in this picture, this cervix is not yet effaced, becomes effaced and dilated at the same moment. Effect of cervical dilatation on fore and the hind water. In normal labor, the head fits well in lower uterine segment. By this, the amniotic sac is divided into a bag of fore water, this one, and hind water above. A bag of fore water below the girdle of contact here, and the hind water above it. This decreases the pressure in the fore water, preventing rupture of membrane. After full cervical dilatation, as in this picture, the hind and the fore water becomes continuous. As you see, they become continuous after full cervical dilatation. And the pressure in the fore water increase. The pressure will increase here, so causing rupture of membrane. What about of phases of cervical dilatation according to Friedman curve? We have latent phase and the active phase. Locked to this curve, this part of Friedman curve is called latent phase. Initial slow phase, dilatation occur up to 3 cm within 8 hours. While this area is called the active phase. Rapid phase, dilatation from 3 to 10 centimeter occur within 6 hours. It includes 3 parts: acceleration phase, maximum slope phase, this area, and the deceleration phase. So this is called the active phase. So we have latent phase and active phase, and the active phase divided into acceleration phase, maximum slope phase, and deceleration phase. Second stage of labor constitutes the delivery of the head and the delivery of the shoulder and body. Delivery of the head includes descent of the head, engagement, increased flexion, internal rotation, extension, and restitution. Descent of the head occurs due to uterine contractions and retractions, and by the effect of auxiliary forces, involuntary and voluntary uterine contractions, and by the unfolding of the fetus. Engagement. The head is said to be engaged when the widest transverse diameter, which is the biparietal diameter, has passed the plane of pelvic inlet. This is the biparietal diameter pass through the plane of pelvic inlet, as you see. And according to delay, the lower part of the first vertex, when felt vaginally, when reached the level of the ischial spine, it's called level 0. This is the engagement of the head. 1 centimeter below that is called plus 1, 2 centimeter below is called plus 2. If above it, above the level 0, at the level of the ischial spine, it is not engaged. It's called the minus 1, minus 2, or minus 3. Also can be diagnosed abdominally by the rule of fifths. Less than 2/5 of the head can be felt abdominally, so the head is engaged. The head normally engages in the oblique diameter or transverse diameter of the inlet. Next step after descent and engagement is increased flexion. As in the picture, this occurs when the vertex meet the pelvic floor. The significance of the flexion: the smallest longitudinal diameter of the head, the suboccipitophragmatic, 9.5 centimeter, pass through the purse canal instead of suboccipitofrontal diameter, which is 10 centimeter if it is incompletely flexed. The occiput will meet the pelvic floor preparatory to the next movement of internal rotation. Lastly, the part of the head applied on the maternal passage is like a pole with equal longitudinal and transverse diameter. Both suboccipitophragmatic and the biparietal diameter 9.5 centimeter, and they are equal. Fourth step is called internal rotation. When the occiput meets the pelvic floor, first, after increased deflection, it undergoes internal rotation 8th circle in anterior position, but rotates 3/8 circle in posterior position, which is known as long anterior rotation, so that become opposite the symphysis pubis. The occiput become opposite the symphysis pubis, as you see here in the picture. This is the occiput become opposite the symphysis pubis after rotation. So rotation 8th circle, so the occiput become opposite the symphysis pubis. This is called internal rotation. Next step is called extension of the head. The head is delivered in extension. The suboccipital region pivots beneath the symphysis pubis, and then by movement of extension of the head, the forehead face comes out successively, as you see in the picture here, the delivery of the head in extension. Restitution. It is the movement of untwist where the head, after delivery, moves 8th circle in the opposite direction of internal rotation to undo the twist of the head on the body produced by internal rotation. As you see in this picture, we have here the extension of the head. Then the next step is restitution, which is undo to the twist of the head on the body produced by internal rotation. Then we'll complete the rotation by external rotation of the head, another 1/8 circle When the anterior shoulder meets the pelvic floor, it rotates forward 8 so in the opposite direction of the internal rotation and in the same direction of the restitution, and this movement is transmitted passively to the head. So the head rotates in the same direction as restitution, another 8 so. So in left occiput to anterior, the face will be directed to the right side of the mother. Delivery of the shoulder and the body. The anterior shoulder, as in the picture here, hangs below the symphysis pubis and the delivery. Then the posterior shoulder is delivered by lateral flexion of the spine, followed by the body. This is the delivery of the shoulders and the body. What about third stage of labor? Third stage of labor includes separation, descent and expulsion of the placenta, separation of the placenta by two mechanisms, Schultz and Duncan. Schultz is more common, or 80% separation occur at the center, and the placenta is delivered like inverted umbrella. While Duncan method constitutes the minority, 20% separation occur at the edges, and this is associated with more bleeding and more occurrence of intrauterine remnants. Then descent of the placenta from the upper segment to the lower segment of the upper part of the vagina, and the expulsion completely out of the vagina, helped by the auxiliary force. Fourth stage, 1 or 2 hours follow-up for women following the delivery of the placenta. Ensure the presence of good uterine contraction and measure the amount of vaginal bleeding, if any, and evaluate the vital signs and the general condition of the woman. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.